Hi everyone, my name is Venus McHugh, and today I will be presenting to you my scholarly project, Do Unit-Based Nurse Practitioners Increase Nursing Satisfaction Levels? My committee members consist of Dr. Snell, who is the DNP chairperson, Susanna Wosu, who is my second reader, and Dr. Stefan Nagu, who is my committee member. Evidence suggests that registered nurses have a large impact on the success of a hospital. Nurse job satisfaction has been linked to increased nursing turnover rates, poor patient satisfaction, increased costs, as well as adverse events. Currently, the nurse turnover rate in the United States is anywhere between 8.8% to 37%, depending on geographical location and specialty. In addition, nurse turnover rates are costing hospitals an average of $4 to $7 million each year. Therefore, strategies on ways to improve nursing satisfaction levels are a priority for optimal outcomes. One strategy to increase nursing satisfaction levels is to have a unit-based nurse practitioner available in an acute care setting. So why are unit-based nurse practitioners so important? The review of literature suggests that unit-based nurse practitioners increase staff satisfaction, improve throughput, decrease length of stay, as well as reduce hospital charges. The role of the unit-based nurse practitioner in an acute care setting is to rapidly intervene, provide care intervention, improve staff knowledge, and mentor staff. Unit-based nurse practitioners are readily available to provide advanced physical assessment, clinical-related skills, order tests, medications, provide clinical leadership, patient and family intervention, and lastly, a visible source of clinical leadership. Job dissatisfaction among RNs contributes to nurse burnout, turnover, retention issues, and costly labor disputes. A survey examining over 95,000 nurses showed an increase in higher dissatisfaction in acute care hospital settings. Hospitals are always looking at ways to increase nursing satisfaction, and having a unit-based nurse practitioner readily available is one way to increase RN satisfaction levels. The purpose of the scholarly project was to increase satisfaction levels with unit-based nurse practitioners by providing hands-on clinical support as a visible source of clinical leadership. The research question proposed, do unit-based nurse practitioners increase nursing satisfaction levels? Keywords that were utilized for this literature review are hospital-based nurse practitioners, staff satisfaction, patient outcomes, and cost effectiveness. The common theme among the literature is that hospital-based nurse practitioners are knowledgeable, team builders, decrease mortality and morbidity, decrease length of stay, and provide overall high quality of care. The literature suggests that nurse practitioners increase staff satisfaction through team building, communication, support, holistic and team approaches, good source of knowledge, intervention, and quality dialogue with one another. Nurse practitioners demonstrate time after time that they are effective providers that provide optimal care to patients by decreasing length of stay, decreasing mortality, morbidity, complication rates, readmission rates, and are cost effective. They follow guidelines creating a better prognosis for the patients, as well as an increase in patient and family satisfaction. As previously mentioned throughout the literature, the common theme is that nurse practitioners decrease length of stay, mortality, morbidity, readmission rates, as well as complication rates. The salary of the nurse practitioner is half of the physician's salary, making them a good economic addition in a hospital setting. The theoretical framework that best fits this project is the comfort theory by Catherine Kolkaba. Comfort occurs in 4 ways: physical, psychospiritual, environmental, and socioculture. The nurse practitioner must establish a trusting relationship with the nurses, patients, and families. If the nurse practitioner can establish a comfortable and trusting relationship within their prospective setting, optimal care will be achieved. This project took place at a 200-bed rural community teaching hospital in East Norriton, Pennsylvania. The implementation occurred on 4 East, which is a 36-bed telemetry COVID-19 unit. IRB was obtained by Maryville University, and a letter of support was provided by the facility where the implementation occurred. The design of this project was one of convenient sampling. It's a quantitative study of night shift RNs who only work on 4 East with a pre and post implementation survey. The participants were recruited via email. They received a hyperlink to Qualtrics that was attached to the email. Once they clicked it, it would go automatically to the informed consent page explaining in detail what the project consisted of. If they chose to move forward and hit yes, they would be taken to an electronic survey. If they chose to not move forward and hit no, they would just be taken out of the survey altogether. The inclusions for the participants was that they must have a registered nurse title, be a full-time employee with an associate's degree or higher, greater than 20 years old, work on night shift, and can only work on 4 East. The exclusion criteria were those who are not registered nurses, less than 20 years old, who work any other shift other than night shift, those who work on any other floor other than 4 East, and those who are per diem or part-time employees. This project took approximately 1 year to complete, from choosing a topic to researching it, implementing it, and then measuring and collecting the data. The implementation occurred on April 12th. An email was sent to the participants for them to complete the pre-implementation survey. They had 1 week to complete the survey, in which they ended on April 18th. The following day, April 19th, the implementation began. The unit-based nurse practitioners sat on 4 East for that week on night shift to provide hands-on clinical support when needed. The intervention completed on April 25th. The following day, April 26th, the post-implementation survey was sent back out to the participants. They had 1 week to complete the survey, and it was ended on May 2nd. 25 emails were sent to potential participants. They were given a hyperlink to Qualtrics explaining the study. 22 participants met inclusion, which is an 88% response rate. The measurement tool utilized was a 3-point Likert scale with yes, no, and sometimes responses. There was also 1 select all that apply. The participants received the same questions pre and post survey intervention. There were 10 forced questions, with 4 being demographic, which was in the beginning of the survey. Upon completion of the survey, it was analyzed and measured in Qualtrics. It was then extracted from Qualtrics and brought onto Excel. From Excel, it was then imported to SPSS, where it was measured, collected, and analyzed. Some of the ethical considerations of this project was that it was a web-based survey, all participation was voluntary, electronic implied consent, there was no identifying personal information, and lastly, the participants were able to withdraw up until the survey was completed. Frequencies were calculated for each survey responses upon completion of the survey. The Mann-Whitney U tests were conducted to determine if there were a difference between the pre and post intervention. These non-parametric tests were utilized as the data collected was ordinal data. Bar graphs were utilized to compare items between different groups. This visual was effective in capturing the pre and post implementation survey questions while comparing the data in each time point. This table shows the demographic variables of the participants at pre and post implementation test points. What stands out about the demographics of the participants is that 20 of the 22 are female and only 2 were male. 10 of the participants are between the ages of 20 and 30. 18 of the participants hold a bachelor's degree, and 14 of the participants have been practicing 0 to 5 years as a registered nurse. This figure shows the proportion of responses to each item for the 2 time points, pre and post. None of the items were significantly different from each other. All p-values were greater than 0.17. implying that the implementation did not have an effect. However, it should be noted that the items, would you prefer to have the APPs more present on 4 East for night shift? And do you feel a unit-based nurse practitioner on night shift would increase nursing satisfaction? Had a large proportion of positive responses in both time points, which could explain why these items did not have a significant change. One item, having a unit-based nurse practitioner on 4 East, required participants to select any response options that applied. This figure shows the frequency of responses to each option for each time point. Overall, attitudes towards nurse practitioners were positive. The majority of participants at both time points felt that the positive statements were applicable, and only one participant in the post-intervention group selected that nurse practitioners do not make a difference. Finally, the last item of the survey asked your overall satisfaction with nurse practitioner support at night. This figure shows the proportion of responses at the 2 time points, pre and post intervention, and shows that the proportions of responses were identical. As such, the Mann-Whitney U test was not statistically significant, p = 1. According to the data, nurse practitioners are very favored among the RNs. However, this intervention had little impact in the study results. The intervention in this study did not influence nursing satisfaction levels. There was no significant change with the intervention. This may be due to the nurse practitioner already being favored by the RNs, or the intervention just did not work. This intervention may not have been effective. However, the RNs have positive views towards nurse practitioners. The strengths of this study are that it's generalizable, meaning that a broader focus of research can be completed off of this study. For example, the study was only done on night shift, so maybe they can do it on day shift, on a med-surg unit, on a telemetry unit. They don't have to just limit themselves to one specific unit. Also, unit-based nurse practitioners are favored among the staff and patients. Again, this research project was done on a telemetry unit, which is one of the strengths because most of the research has been in the intensive care. And I can tell you that my colleagues here at the hospital, there is a unit-based nurse practitioner in intensive care where she will sit there all day on day shift to respond to anything that may be occurring. And lastly, complementary role. And this is my favorite part of my job. There's alternative roles and complementary roles of nurse practitioners. Usually your day shift are more of the alternative roles to where, they'll bill, they'll go in and plan care, they'll discharge. Whereas on night shift, it's complementary. You're there to support the physician. However, you're doing everything basically hands-on for the patient. You're not doing any discharges. You're not doing any billing. You're just there to put fires out throughout the night. And that's one of my favorite things about being a practitioner on night shift. Some of the limitations of this study are that it was a single hospital study. It was limited to registered nurses who work only on night shift and on one specific unit. The exclusions made for a small sample size of 22 participants. Another limitation are that the participants could not be matched. The nurses did not want to be given identifiers and Qualtrics. Although it was explained to them that their confidentiality would be remained, their preference was to not be given identifiers, leading to not knowing who did the pre- and post-intervention study. This was not going to affect the results, so that's why I allowed it to go through. Also, the day the survey went out, the nurses found out that the nurse practitioners were going to be replaced by the residents. This made them very upset as they prefer the nurse practitioner over the residents. So this could have had an impact on the study as well. Lastly, the Likert scale was used for this study, and it was the 3-point Likert scale with yes, no, and sometimes questions, and one select all that apply. This was most certainly a limitation to this study, as the nurses really didn't have anywhere to move up. For example, if they were asked, are you satisfied with nurse practitioners in the pre-intervention study? They said yes. And then after the implementation, they were asked, are you satisfied with nurse practitioners? They said yes. There was no room to grow. So in hindsight, I really should have chosen a Likert scale, maybe 5-point or even 7-point, so that they could have changed their answers. And I think then it would have been effective. So I personally believe that this whole entire study was affected by my measurement tool. And I wish I would have, done it that way. But it's a learning experience, and moving forward, I would know to do that now. Implications for future research. What I've discovered the past year of researching this topic is that nurse practitioners are underutilized in acute care settings, and in some regions they aren't allowed to practice to the fullest extent of their education. Most of the literature suggests that nurse practitioners provide optimal care, yet they are still being underutilized. Future research is indicated for medical, surgical, telemetry, obstetric, psychiatric units. We just need more literature on unit-based nurse practitioners being in different specialties or on different units. Most of the literature is currently in the intensive care. However, we need more research on the other units as well to see what the outcomes would be of having that practitioner there. Also, staff satisfaction and patient outcomes. Does staff satisfaction affect patient outcomes? If there's a unit-based nurse practitioner and the staff are satisfied, does that affect patient outcomes? If the practitioner is there and the staff is dissatisfied, does that affect patient outcomes? So more literature should be done on that as well. And lastly, alternative and complementary practitioners. So you can provide both. However, it's usually one or the other. So there needs to be more literature when there's a unit-based nurse practitioner. Which are they providing? And what I've seen so far is it really seems as though day shift are the more alternative, provide more alternative treatment, whereas the night shift provides more complementary treatment. So more literature needs to be on this topic, and what would be best if the unit-based nurse practitioner is practicing on a specific unit, and what their function and role would be, and how would it affect staff and patients. In conclusion, the results of this study established that the intervention did not have any significance with the RNs. The pre- and post-intervention survey were not significantly different from each other, implying that the intervention was ineffective. There were, however, a large proportion of positive responses during the pre- and post-intervention favoring the NPs. There was such a large proportion of positive responses during the pre- and post-intervention survey in the NP's favor that it could not have resulted in not having a significant change. If the RNs were already satisfied with the nurse practitioner prior to the intervention, then the intervention would likely not be effective. Because some of the survey responses pertaining to nurse practitioners received such favorable responses, there was not any room to grow, ultimately leading to an unsuccessful intervention. Again, I attribute this to choosing the incorrect measurement. Had I chosen a 5-point Likert scale and utilized that in this study, I believe we would have likely seen a significance in the implementation. Further research is needed on unit-based nurse practitioners and the effects that they have on staffs, patients, and families. Most literature is based in intensive care. Therefore, more research is necessary on unit-based nurse practitioners so that our organizations will adopt this implementation in the future. I'd like to acknowledge Dr. Snell, who was my DNP chairperson. The completion of this scholarly project could not have been possible without your patience, guidance, support, and advice. It was a rocky start finding a topic. However, your expertise in this process led me to a topic that I truly enjoyed working on, and I'm so grateful to you. Also, I'd like to thank each of the Maryville instructors who dedicated their time with each chapter so that I can have the best version of my study. I appreciate each and every one of you. You know, I went to Maryville back in 2012 when I became a nurse practitioner. I had such a wonderful experience at that time. I've referred many people since then in the past 7 years who have all felt the same way as me. I'm really happy that I went back to Maryville for my DNP, and I'm very proud to say that I received it at Maryville. And again, I appreciate all of you for getting me this far, so thank you. And this section will be left open for any questions.